Preterm labor and pre-labor rupture of the membranes, PROM. Preterm labor is defined as labor which occurs from the viability of the fetus, which is completed 24 weeks until the completion of 37 weeks of pregnancy. So, you know that term pregnancy is 40 weeks. Term pregnancy between 37 and 40 weeks. This is called term pregnancy. Any labor before completed 37 weeks is called preterm labor. Delivery before completed 37 weeks is called preterm delivery. Preterm birth is a major cause of neonatal morbidity and mortality. Despite the extensive research, preterm birth still accounts for 5 to 10% of all deliveries in developed countries, and the rate is on the rise. While mortality associated with preterm delivery has declined due to the use of antenatal steroids and improvement in intensive neonatal care, preterm babies remain at risk of major complications, and this is why cost implications are a burden to healthcare systems. Determinants of mortality and morbidity of preterm babies are gestational age at the time of the delivery and birth weight of the baby. Studies have demonstrated improvement from 8% survival at 23 weeks, which is extreme prematurity, to 74% at 28 weeks. This means improvement of 3% per day at such gestation. 8% at 23 weeks to 74% at 28 weeks. Similar improvement are associated with weight, birth weight, for each 100-gram increase in birth weight. Survival rates improve considerably at lower gestational age for each additional week gained in utero. And this is why we say that the uterus is the best intensive care. Preterm birth has a multifactorial etiology, and this is why it's been called by some as a syndrome. Approximately 75% of deliveries occur as a result of spontaneous preterm labor, while the remainder follow intervention for maternal or fetal issues, that is iatrogenic. There are 4 broad pathogenic pathways that lead to preterm labor and birth. Activation of the maternal and fetal hypothalamo-pituitary axis, infection, residual hemorrhage, and pathological uterine distension. All of these lead to inflammatory reaction with the release of prostaglandins and cytokines. Activation of the maternal hypothalamic pituitary adrenal axis can occur prematurely in cases of maternal or fetal stress, and this may stimulate the placenta, decidua, and fetal membranes to release corticotropin-releasing hormone and estrogen. And this corticotropin-releasing hormone stimulates the release of prostaglandin, and with estrogen, this leads to myometrial stimulation and contraction. In pregnancy, there are immune and endocrine adaptations. Hormone signaling, in particular progesterone, from the beginning of pregnancy, early in pregnancy, establishes a receptive endometrium and leads to maternal immune tolerance. This maternal fetal immune tolerance will prevent fetal rejection. Whenever there is an infection, there will be stimulation of the immune response with the release of cytokines, prostaglandins, leukotrienes, and proteases. All of these may start the process of labor, uterine contractions, and possibly rupture of membrane. This process may also be caused by inflammation. So this is overreaction to inflammation or a response to infection. There be a switch from in the local immune environment from quiescent to active, and activation of myometrial contractions and labor. Abruption and smaller bleeds at the choriodecidual interface lead to the generation of thrombin, which stimulate proteases and prostaglandins that activate the myometrium and lead to a myometrial contraction and start labor. Overdistension of the uterus may be associated with situations as polyhydramnios, multiple pregnancy, and uterine abnormalities that can be either due to diethylstilbestrol or due to congenital Mullerian duct abnormality. All of these lead to restriction of normal uterine expansion. And this pathological restriction may lead to stretching of the myometrium and fetal membranes, in addition to myometrial activation and increase in gap junction formation between myometrial cells, and increase in estrogen receptors and prostaglandins, which all in all lead to myometrial contractions with the resultant onset of labor, and in this situation, preterm labor. One of the aims of antenatal care is to identify women at risk of preterm delivery in order to improve perinatal outcome. History is very important. It is the first step when you approach your patients. Previous preterm delivery is a strong predictive factor, and the recurrence risk of preterm delivery increases with the number of previous preterm deliveries. So, history of one preterm delivery increases the risk of preterm delivery by 16 to 19% in subsequent pregnancy. Two previous preterm deliveries increase the risk by 32 to 41%, and the presence of three preterm deliveries increase the risk of preterm delivery by 67%. The gestational age of prior preterm delivery often correlates with subsequent preterm delivery. Women with early prior spontaneous preterm delivery before 28 weeks had a threefold increase in the risk of recurrence, and usually preterm delivery in subsequent pregnancy will be often around the time of previous preterm delivery. Keep in mind that the presence of previous term delivery decreases the risk of preterm delivery in the current pregnancy. Also, other points in the history, apart from previous preterm delivery, previous PROM, previous preterm pre-labor rupture of the membrane, previous second trimester miscarriages late second trimester miscarriages, congenital uterine anomalies, multiple pregnancy in the current pregnancy, because women who originally delivered twins preterm are not at increased risk of recurrence of preterm deliveries in subsequent pregnancies. So when we talk about multiple pregnancy as a risk factor or as a predictive factor, it will be in the current pregnancy. Vaginal bleeding, first trimester bleeding, and the presence of a short cervix that the patient is aware of, and previous treatments to the cervix or cone biopsy. So this is by history, taking previous obstetric history. The risk of spontaneous preterm delivery increases with maternal age and decreases with height. It is also higher in African and South Asian origin compared to white population. The risk increases in smokers and in women conceiving after induction of ovulation. Screening by obstetric history alone will identify only 10% of women who will go into preterm labor and delivery based on their previous obstetric history. There were a large number of studies to assess the value of ultrasound in the assessment of the cervix as a screening test and as a predictive test for preterm labor and delivery. The normal cervical length is 3.5 centimeters. And from these many studies, the cervical parameter that was found to be predictive of preterm birth is when the cervix is less than 25 millimeters. If we have a symptomatic woman presenting with preterm labor, you measure the cervix and you find it longer than 3 centimeters, then there is no risk of preterm delivery, while if it is shorter than 2 centimeters, there is a significant risk of preterm birth. In asymptomatic women, if you find a cervix less than 1 centimeters, there will be a significant increase in the risk of preterm labor. This is why we do serial transvaginal scans to measure the cervical length in high-risk women for preterm delivery, starting from 16 weeks of pregnancy or starting between 16 and 24 weeks of pregnancy, and we may offer cervical cerclage if the cervix is shorter than 25 millimeters. To measure the cervical length, we use the transvaginal scan because it is more accurate. We use it with an empty bladder. A transvaginal scan is more accurate than a transabdominal scan. A transabdominal scan requires a full bladder to measure the length of the cervix, and actually this may give the look of a longer cervix, while a transvaginal scan, we measure the distance between the external os to the internal os in the absence of funneling, while in the second picture, in the presence of funneling, we measure the distance between the external os and the functioning internal os. How to evaluate women when they present with abdominal pain or labor-like pain? The most common cause of abdominal pain in pregnancy is labor pain, term or preterm labor. For those who had labor and delivery before, will describe the pain they're presenting with as labor pains. If they did not labor before, they will describe it probably as menstrual-like cramps or colicky pain on and off in association with show, which is the mucousy plug with a tinge plug with a tinge of blood. It could be also associated with bleeding or rupture of membrane. Some pelvic pressure may be felt with the presenting part coming low in the pelvis. Increased vaginal discharge as a symptom of labor. It can be present also with preterm labor. Urinary and bowel symptoms can be either a cause of the preterm labor, the infectious process, or differential diagnosis as a cause of the abdominal pain. On examination, always start by the systemic look of the patient, body mass index, vital signs, and then do abdominal exam. When you do the abdominal exam, what are we looking for? Yes, we do the obstetric exam, Leopold maneuvers. Looking for what? Looking for the symphysis fundal height. Is it with date or not? Less or more than expected? Lie of the baby and presentation. We also feel for tenderness, looking for abruption. With abruption, the tenderness is usually localized. Uterine contractions, labor contractions, the tenderness is usually generalized. With chorioamnionitis, again, the tenderness could be generalized. We do a speculum exam. Why to do a speculum exam? We don't rush to do a digital vaginal exam because we may stimulate the release of prostaglandin and that may increase contractions or introduce infection. We do a speculum to look for cervical dilatation and in the presence of a history of rupture membrane or leakage of fluid, look for pooling of amniotic fluid or bleeding and abnormal vaginal discharge. Digital vaginal exam will be required in the presence of regular uterine contractions. So on admission of a lady with preterm labor pains, we don't rush to do a digital vaginal exam unless she's having regular uterine contractions. We do one on admission. You may repeat it after 4 hours earlier only if necessary. When a pregnant woman presents with abdominal pain in pregnancy, think of the commoner causes first. The most common, the most likely cause of abdominal pain in pregnancy is labor pain, term or preterm. At any time from 24 weeks till term, any abdominal pain, think first, is this labor or not? Other possible causes: urinary tract infection, placental abruption, gastroenteritis. All of these can be either causes of the pain or risk factors and causes of the preterm labor. Red degeneration of the fibroid. Red degeneration is the classical presentation of fibroids in pregnancy. This is one of the effects of pregnancy on the fibroids, that the fibroid enlarges during pregnancy because it is hormone dependent and it outgrows its blood supply, and this is why it is ischemic pain. The management of red degeneration is by hydration and analgesia. We do not do surgery. We do not remove the fibroids and do myomectomy during pregnancy. How to suspect that this is red degeneration of the fibroid? First, by knowing that the patient had fibroids in the past, or by checking early in pregnancy, when we do an ultrasound, we look at the uterus. We check if there are any fibroids. Because in the third trimester, it is really difficult to see the fibroids. Usually, we are aware that this patient has fibroids, and this is how we can tell that this is red degeneration of the fibroid. But of course, you have to rule out all the possible causes of the abdominal pain. Other possible causes of abdominal pain, of course, obstetric, non-obstetric, gynecological causes. Think common is common. Labor pain is top of the list. Preterm birth means the actual preterm delivery. Not all women who present with preterm labor will deliver. And this is why sometimes you read not preterm labor, it will be threatened preterm labor. 90% of women presenting with threatened preterm labor will not deliver within 7 days, and almost 70% will deliver at term. The usual method that we do to assess women when they come in with threatened preterm labor is checking the uterine contractions if they have regular uterine contractions, and we may do a vaginal examination to check for cervical dilatation. But both have poor predictive value. And this is why we need other tests to help us in the diagnosis and prediction of preterm labor in the current pregnancy for someone who's presenting with labor-like pain. Fetal fibronectin is an extracellular glycoprotein found in high concentrations in cervicovaginal secretions before the fusion of the membranes at around 21 weeks of pregnancy. Disruption of the choriodecidual interface leads to the secretion of fetal fibronectin into the cervix and vagina. Based on this, if we do swabs from the posterior fornix or ectocervix, we can detect fetal fibronectin by ELISA. Usually this is done between 22 and 34 weeks of pregnancy when you don't expect to see fetal fibronectin in the secretions. The importance of this test is the negative predictive value. This means if the test is negative for fetal fibronectin, this means around 97% of the women will not deliver within the next week. You can send the patient safely home. But if it is positive, it means that around 13% might deliver within the next week, and this is the one with a positive test that you will admit to the hospital and manage accordingly. We usually do the test between 22 to 34 weeks. You can see in this slide contraindications before the age of 24, because in some references it is not advisable to be done before 24 weeks. Just if you know the basis of the test, do the test between the 24 to 34 weeks of pregnancy. If there is rupture membrane, preterm PROM in multiple pregnancy, or if the cervix is more than 3 centimeters dilated. This means that the patient is in active labor. This is diagnostic on its own. You do not need to do fetal fibronectin. If there is active vaginal bleeding, don't do the test. If you've already done a digital vaginal exam, or if the patient had intercourse within the last 24 hours, or if a lubricant gel was used, it is contraindicated to do fetal fibronectin testing. Other biochemical markers are present, but these are not used in our clinical practice. These are for research issue mostly. So you take a history, you do physical exam. In the history, you ask about the fetal movement, and on examination, you have to examine the baby. Examination of the baby, including listening to the fetal heart by either a sonicate and doing a cardiotocograph, CTG. Also, an ultrasound is recommended to document, to confirm the presenting part of the fetus, because sometimes it can be hard to differentiate cephalic from breech presentations with preterm baby. So with an ultrasound confirm fetal presentation, you can estimate the fetal weight, check the age of the baby, and check the amount of the liquor. So your approach when you have a pregnant woman presenting with abdominal pain is to take a history first, current history analysis of the pain, associated symptoms of leakage of liquor, bleeding, passage of show, pressure symptoms if the presenting part is coming down. Also ask about urinary symptoms and bowel symptoms. Fetal movement, make sure for all pregnant women to ask about the fetus along with the history of the mother. You need to know the past obstetric history, because knowing that this lady had a previous preterm delivery increases her risk of another preterm delivery in the current pregnancy. Do physical exam and then testing. What testing do we need? Actually, we need urine analysis and culture to rule out UTI. You may need fetal fibronectin, as we said, to decide if it is negative. You can send the patient home. If it is positive, admit the patient and manage by possibly tocolytics and steroid injections. History, physical exam, differential diagnosis, and management. How to manage a woman with a threatened preterm labor. First of all, bed rest was not found. There's no evidence that bed rest improves the outcome. What about the other points in our outline? Hydration. Does it improve the outcome? Actually, yes. And this is why in the month of Ramadan, you see many women presenting with threatened preterm labor. What we do, what happens with dehydration, there will be increased levels of ADH, and ADH will bind to oxytocin receptors and lead to uterine contractions. And this is why what we do, if the woman can't tolerate oral hydration, we give her oral hydration, otherwise IV fluids. And we recommend that she lies on her left side to improve blood flow to the uterus. Maternal steroid injections decrease respiratory distress syndrome by stimulating surfactant production, and also reduce neonatal death and intraventricular hemorrhage. They should be given between 24 and 34 weeks, although this may be given up to 36 weeks. We may use betamethasone or dexamethasone. There is no difference, although some references claim that betamethasone is the agent of choice. The doses are usually given by IM injection because oral administration of betamethasone was associated with higher rate of neonatal sepsis and intraventricular hemorrhage compared to intramuscular injection. This is why steroids should be given by IM injection and not orally. The optimal benefit is achieved within a steroid window of 24 hours and up to 7 days after the last injection. And this is why in the past we used to give recurrent courses of steroids, but after that multiple studies evaluated the use of single versus multiple courses of corticosteroids and resulted in the conclusion of giving only one course of steroids. We have the situations when women present at extreme ages of prematurity, let's say at 26 weeks, when we give steroid injections and they don't deliver and they present again at 30 weeks. We may consider rescue steroid injection, and this needs to be evaluated individually. Keep in mind when you give steroids to patients that it may cause glycemic disruption in diabetic women or those with gestational diabetes. So make sure you consider glucose sliding scale. A variety of tocolytic agents are available for the management of preterm labor. These agents inhibit myometrial contractility. When to consider giving tocolytics? What are the indications? Actually, we give only two indications. First one is to complete a course of steroids, and the other one is in utero transfer. If the patient presents with a history of receiving a course of steroids, you don't need to give tocolytic, or if she's in a tertiary center where you don't need to transfer her to another unit, then there is no need for tocolytics. We should only consider tocolytics if the few days gained would be put to good use. And as I said, good use is the two indications only: giving steroids or complete the course of steroids and in utero transfer. The available agents are as apparent from the list. We're going to discuss them all. Once a decision has been made to use tocolysis, the best choice of medication depends on the possible maternal and fetal side effects and the unit you're working in. Starting by the beta-2 agonists, which are the beta-2 sympathomimetics, which act on beta-2 adrenoreceptors in the myometrial smooth muscles via cyclic AMP-dependent mechanism, leading to the reduction of intracellular calcium and therefore muscle relaxation. There are possible maternal and fetal side effects. The available medications are ritodrine with the trade name of Utipar, and I used this very frequently during my residency, during my obstetric training, terbutaline and salbutamol. Maternal side effects include palpitation, flushing, nausea, headache, hypotension, chest pain, cardiac arrhythmias, pulmonary edema, this is very important, hyperglycemia and hypokalemia. Fetal side effects include tachycardia at high doses, hypoglycemia, hypocalcemia, ileus, and hypotension. It is contraindicated in patients with symptomatic cardiac disease, uncontrolled diabetes, hyperthyroid, and also relative contraindications in patients with multiple pregnancy. Because of maternal and fetal side effects, this agent should no longer be used as a first-line tocolytic agent. Atosiban is a specific oxytocin analog that acts on oxytocin and vasopressin receptors. It has less side effects when compared to beta-2 agonists, but similar effectiveness. The problem is that it is expensive when compared to probably nifedipine, and atosiban was specifically licensed for preterm labor, and it seems that it has a clear maternal safety profile, and this is why many doctors and units use this as first-line tocolytic agent. Nifedipine is a calcium antagonist which can be given orally, and it is also cheap, but it is not licensed for the use of preterm labor. But the Royal College of Obstetrics and Gynecology recommends nifedipine and atosiban as tocolytic drugs of choice as a first-line tocolytics. But because nifedipine is not licensed, there is no consensus on the ideal dose regimen for nifedipine when used for tocolysis. It is the drug of choice for in utero transfer. When you transfer to another unit, oral medication will be the best medication. Indomethacin is a non-steroidal anti-inflammatory medication that inhibits cyclooxygenase enzymes and therefore affects prostaglandin metabolism. To remind you, prostaglandins increase myometrial contractility by increasing the gap junctions between myometrial cells, increasing oxytocin receptors, and increasing intracellular calcium levels. Indomethacin has maternal and fetal side effects. Maternal side effects: peptic ulcer, gastrointestinal bleeding, thrombocytopenia. A list of possible maternal side effects, while the fetal side effects include premature closure of ductus arteriosus, pulmonary hypertension, renal impairment, oligohydramnios, and there is increased risk of neonatal necrotizing enterocolitis and intraventricular hemorrhage. And this is why this medication is not used as a tocolytic agent anymore due to the concerns over the fetal side effects. Magnesium sulfate is a tocolytic agent, but we don't use it for this reason. We use it for neural protection, especially in extreme preterm babies, where magnesium sulfate was found to protect or to reduce the risk of cerebral palsy and protect the gross motor function in babies born prematurely. As we said, magnesium sulfate is a tocolytic agent, but we use it for neuroprotection. Antibiotics are not required in uncomplicated preterm labor, but if there is a preterm PROM, then we have to give 10-day course of erythromycin, and there is evidence that the neonatal outcome will be improved. Some give antibiotics for preterm labor ladies if the group B streptococcus status is unknown. If a lady presents to a unit where intensive care unit, neonatal intensive care unit, NICU, or special care baby unit are not available, then the lady should be transferred to another unit, and this is what we call in utero transfer. Mode of delivery of preterm babies should be individualized, although the general consensus would favor vaginal delivery before 26 weeks of gestation. Between 26 and 37 weeks, obstetric factors are the ones to be considered to decide mode of delivery. Caesarean section before 28 weeks of pregnancy is more likely to be a classical caesarean section in the absence of a well-formed lower uterine segment, and this will have implication for the mode of delivery in the future pregnancy and risks of adherent placenta. There is no evidence to support the practice of doing a prophylactic forceps, outlet forceps delivery or elective episiotomy with vaginal delivery to protect the baby. But delay clamping of the cord have been suggested to auto-transfuse the neonate at delivery. Outcomes of preterm labor and birth will be maternal and fetal outcomes. Maternal complications are associated with tocolytic agents, complications, side effects of the medications, or the underlying cause, or a cesarean section delivery with its associated complications. Remember the psychological aspect and the risk of postnatal depression, and this is why we usually arrange a debriefing session for couples 6 weeks or earlier after delivery. We bring them back and discuss the events of admission and delivery, and we formulate a plan for future pregnancies. This is when we tell the patient what to do in the next pregnancies to prevent further preterm deliveries. With the neonatal outcome, prematurity is the leading cause of newborn deaths, according to the WHO in 2012, and it is the second leading cause of death in children under 5 years of age. And still, in extreme premature gestational ages, prematurity is associated with neurodevelopmental impairment, educational difficulties, and changes in social behavior. Complications also include respiratory distress syndrome, necrotizing enterocolitis, intraventricular hemorrhage, cerebral palsy, premature ductus arteriosus, jaundice, hypothermia, difficulty in feeding, chronic lung disease, and retinopathy. Can we prevent preterm delivery? The answer is yes, this is possible. And this is why I said earlier, whenever we have a preterm delivery, we have to debrief this woman and formulate a plan for future pregnancies. So you advise on minimizing risk factors as smoking, weight, diet, and alcohol. We treat vaginal infections, especially with late second trimester miscarriages, manage asymptomatic bacteriuria. In high-risk patients, we said we do a transvaginal scan to measure the cervical length and manage accordingly where the cervical suture may be considered. A pessary was used by some studies in singleton pregnancies, and there is no role for prophylactic tocolysis. There are two randomized controlled trials in singleton pregnancies with a history of previous preterm birth showing a reduction in the risk of delivery before 37 weeks with progesterone supplementation. So to prevent preterm delivery, we give these women at high risk progesterone supplementation all through pregnancy. Improved perinatal outcome is not demonstrated, and this effect was noted in singleton pregnancies but could not be seen with multiple pregnancies. PROM, pre-labor rupture of the membrane. PROM, preterm pre-labor rupture of the membrane. People used to call it in the past premature rupture of the membranes, but then because we have term and preterm PROM, the name has been changed to pre-labor rupture of the membranes. Pre-labor rupture of the membranes, PROM. This is defined as rupture of the membrane before the onset of labor. This can be either term, from 37 weeks onwards, or preterm before 37 weeks of pregnancy. So PROM at term, and we have PROM, preterm pre-labor rupture of the membrane. PROM complicates 3% of pregnancies, and it is associated with 30 to 40% of preterm deliveries. Spontaneous onset of labor after term PROM usually follows within 24 hours. The median latency after PPROM is 7 days, and this tends to shorten as the gestational age increases. Latency period at 26 weeks, you can see that 50% will deliver within a week, while 50% of rupture membrane at 32 weeks will deliver within 24 to 48 hours. A woman presents with a gush of fluid per vagina. Take a proper history. A pregnant lady with a gush of fluid, which will be continuous dribbling. The classical history, the woman will tell you that she was sitting or whatever she's doing, all of a sudden she had a gush of fluid leaking on both her legs, or she felt something hot coming down on both her legs. Take a history, the details and timing of the gush. What were the associated symptoms? Was she in the toilet or not? Keep in mind, is this amniotic fluid or urine? Amount, was it minimal amount or a gush followed by continuous? It is important with rupture membrane for the leakage to be continuous. The color depends. Usually it's clear to yellowish, but if it is blood stained, this could be with a show, or keep in mind the possibility of abruption, and it could be greenish in the presence of meconium, which could be an evidence of fetal distress. Ask about urinary symptoms, abdominal pain, uterine contractions. This is very important. It is important to remember when rupture membrane occurred before admission. On examination, start by the general look of the patient. Check the vital signs, pulse rate, temperature. Maternal tachycardia and fever may reflect infection. Our main concern is chorioamnionitis. This is the infection we're worried about. is the patient well or not? Body mass index is always important in obstetric exam, keep it in mind. Then we do the obstetric abdominal exam, Leopold maneuvers to find the symphysis fundal height, lie, and presentation, because if you're delivering, you want to know what will be the mode of delivery, tenderness in case of chorioamnionitis. This should be followed by a sterile speculum exam. This is the gold standard diagnosis of rupture of membrane, pre-labor rupture of the membrane. When we do the speculum, what we see, we look for a pool of the fluid, pool of amniotic fluid, a positive cough sign. You ask the patient to cough and you see liquor coming through the cervix. At the same time, what you do is you visualize the cervix and check if it is dilated at all, and we want to rule out cord prolapse. Remember, no digital examination is allowed because of the risk of infection. History, physical exam, and speculum to confirm the diagnosis. If you see liquor by the speculum, that's it. You can say that this is PROM, pre-labor rupture of the membrane, term or preterm. Differential diagnosis includes urine, as I said. It could be vaginal infection or leukorrhea, as there is excessive vaginal discharge in pregnancy. Do we really need other investigations to confirm the diagnosis? If you see liquor coming through the cervix, the positive cough sign, or if you see pooling, actually you don't need to do any further testing. But these investigations were done in the past. Nitrazine test, where you put a stick that changes in color to black because of the alkaline pH of the liquor. This can be false positive. The Ferning pattern, when you take a drop of amniotic fluid on a slide and leave it to dry and look at it under the microscope, you see the Fern pattern. These may confirm the diagnosis. A high vaginal swab is not really required to confirm the diagnosis, but we usually do it to screen for group B streptococcus. An ultrasound is not important for the diagnosis. Actually, the role of ultrasound in the diagnosis of PROM is not clear. But if oligohydramnios can be demonstrated, this may confirm the diagnosis of PROM. Amnisure is a test that detects placental alpha microglobulin 1, and it is highly sensitive with 100% specificity and does not require a speculum exam with no gestational age limitation. And this is very important because whenever you have a woman presenting with a history suggestive of rupture membrane, you do a speculum, you see liquor, this is diagnostic. If you don't see liquor but the history is really suggestive, then you can do amnisure test. In 10 to 20% of cases, the findings will be equivocal. You do a speculum, you cannot demonstrate the pooling of liquor, and you cannot see the positive cough sign. And this is when you either ask the patient to wear a pad and walk around and check again, or the better test is to do amnisure, as I said. Our main concern with PROM is the PROM, preterm pre-labor rupture of the membrane, because it is associated with neonatal morbidity and mortality. With preterm PROM, remember this is associated with preterm delivery, so complications are usually prematurity, cord prolapse, placental abruption, chorioamnionitis infection, hyaline membrane disease, pulmonary hypoplasia, fetal distress. This is usually with prolonged rupture of the membrane and rupture membrane at extreme gestational ages. The same applies to fetal deformities. Diagnosis of chorioamnionitis, which is our main concern, infection. Usually it should be a combination of clinical symptoms in addition to blood tests and fetal heart rate. Clinically, if the woman has lower abdominal pain, smelly vaginal discharge, fever, malaise, and reduced fetal movement. Blood tests, we usually request C-reactive protein and white cell count. If they are raised, these are suggestive of infection. And in the presence of fetal tachycardia, more than 160 beats per minute, this is again suggestive of chorioamnionitis. If you suspect and diagnose chorioamnionitis, the management is usually immediate delivery. If this was on admission, you can start by giving the first dose of steroids, give antibiotics, and deliver as soon as possible, because this may lead to maternal sepsis and later death. Once the diagnosis of PROM is confirmed, the next steps in the management will be first admission. With a PROM, we always admit women to the hospital because, as I said, they may go into labor and deliver. Then we start oral antibiotics, erythromycin, for 10 days. There is an evidence that oral erythromycin with rupture membrane will prolong the latency and improve the neonatal outcome. Give steroids, as we said, for preterm pregnancies between 24 to 34 weeks. IV magnesium sulfate between 26 weeks and 30 weeks. After that, you don't need to give magnesium sulfate. Of course, remember to make sure you check maternal and fetal well-being. Maternal well-being by taking a history, symptoms of infection, and physical examination, signs of infection, lab tests, white cell count and C-reactive protein, CTG, check fetal heart, make sure there is no fetal heart tachycardia. Tocolysis is not recommended because it will not improve the neonatal outcome. Amnioinfusion is not used anymore. This was used in the past in extreme gestational ages to prevent oligohydramnios and therefore prevent fetal deformities, and it was used in labor to prevent cord compression and fetal distress. With PROM, when to deliver? The most recent Green Top guideline in June 2019 recommended that with a PROM between or after 24 weeks of pregnancy without any contraindications to continue the pregnancy, we offer expectant management until 37 weeks and then induce and deliver. Mode of delivery will be decided by the obstetric indication. Contraindications or indications to terminate pregnancy after rupture membrane, you can tell the presence of complications as cord prolapse, abruption, or going through labor. Term PROM management can be either immediate induction or augmentation of labor. This is associated with less hospitalization, less perinatal infection, and less neonatal morbidity. Some units offer expectant management and they don't immediately deliver. Expectant means that they send the patient home if she's a low-risk lady and bring her back in 24 hours if not in labor and augment.